I'm Charles Nelson. I'm Chief Executive of Malaria Consortium and have the privilege of chairing the first session this afternoon. Joining me on the panel are some of our esteemed guests. I have with me Bernard Nahlen, who has been Deputy Coordinator of the US President's Malaria Initiative since 2007, is a doctor by background and been with the Centers for Disease Control, among other things. He's been a technical advisor to the WHO malaria program. So I also have with me Desmond Chavasse, Dr. Desmond Chavasse. He's Senior Vice President at Population Services and responsible for organizing their global malaria and child survival program in over 40 countries in Africa. I also have Dr. Godfrey Magumba, who has been implementing programs in Uganda for the last 11 years. He's a country director for Malaria Consortium in Uganda and is currently leading the initiative to deliver 20.5 million nets, long-lasting insecticide-treated nets to the entire population of Uganda. And it's been a very exciting program and one we've been delighted to have the privilege of sharing in. Presenting for us to get the conversation going is Dr. James Tibenderana, who is Malaria Consortium's Development Director and previously Africa Technical Director. And he's been with Malaria Consortium for 8 years, I think, but has had 15 years of experience in epidemiology, infectious disease control, and tropical diseases. So we have a good panel to get us going. The way that these will work is there'll be a 15-minute or so presentation, followed by 5 minutes of questions for clarification on the presentation, and then each of our panelists will be having 5 minutes to sort of respond to the presentation and other thoughts that they have on the topic, followed by a period of questions, which we will have to close on time to move to the next topic after about an hour and 5 minutes. So with that, I'd like to hand to Dr. James Tibenderana to present for us Part 1, Disease Control, Malaria and Neglected Tropical Diseases. Thank you, James.
Thank you very much, Charles. Welcome, everyone, to Malaria Consortium's celebration of its 10-year anniversary. In 15 minutes, I'm going to try to summarize some of the work we've done and the learnings over the last 10 years in disease control, malaria, NTDs. I'd like to point out that the reason we come to work every day is because we're trying to bring to people, the marginalized and the underprivileged, alleviation and protection from communicable diseases, especially malaria. And in doing our work, we emphasize certain core values. These core values will be demonstrated in the presentations today, but hopefully in the interactions we've had with you over the last 10 years. Technical excellence, responsiveness, innovation, results orientation, and collaboration. When we started, we had a very small portfolio. Unfortunately, we have a few people in the room who started that work. Health systems and malaria control, we supported several countries in the region to build the institutional capacity to manage malaria, health worker capacity building, commodity logistics, stock management. In the area of prevention, we were involved in free net distribution, and I'm sure some of you can remember those nets that we had to retreat. I'm sure. And now we have the more sophisticated ones. We were also engaging the private sector to see their contribution towards malaria control in terms of distributing insecticide-treated nets. Home management of malaria. At that time, it was presumptive treatment. And some of the people who actually did the pioneering work to show that are in this room. And Malaria Consortium was instrumental in getting home management of malaria into the health system in some of the countries. And we supported the West African network for monitoring antimalarial treatment. We have transitioned. We have not been static. That transition has been opportunistic, but also purposive. We've used malaria as an entry point to reaching into the health system as well as other communicable diseases. In improving health worker performance in assessing and treating febrile illnesses, in increasing access to parasite-based diagnosis, we've gone into the case management of other major childhood illnesses, pneumonia and diarrhea. We've also gotten involved in improving the diagnostic capacity for pneumonia and the quality assurance systems for malaria microscopy, which in turn are contributing towards quality assurance for tuberculosis. Access is limited by health facilities. And so in trying to extend access using community-based platforms, we've also extended beyond malaria into nutritional rehabilitation in South Sudan, mass drug administration for NTDs, neonatal care, as well as general health promotion. And through trying to build the systems through which our malaria interventions can be delivered and sustaining the impact that we gain, we've had to get into health worker performance improvement, commodity management, diseases surveillance, evaluation of interventions, health information systems, the use of data, and operational research. Vector control, LLINs, other measures, we've managed to extend ourselves into dengue control, lymphatic filariasis, leishmaniasis, and integrated vector control management in Asia. Preventing malaria in pregnancy is one of our key activities. And in trying to get that through the ANC clinics, antenatal care clinics, we've had to improve the services provided through that platform and also ensuring that focused antenatal care is adopted and used. We share our knowledge and our information in various ways. At national level, we're involved in meetings, workshops. We hold one-on-one sessions with malaria program staff. At a global level, we're involved in networks. We attend conferences, technical working groups. We contribute to the Malaria Policy Advisory Committee. And more recently, we're doing a lot more publications, but also writing learning papers to show that we have thought leadership in disease control. In our work on long-lasting nets, we've been able to show that standalone mass distribution campaigns are feasible on a large scale and can rapidly achieve moderate coverage. We've also learned that continuous distribution channels, schools, routine immunization, etc., are essential right from the outset to extend the access frontier and maintain coverage. It's important, though, that in selecting the right channel, models can be used to ensure that you get the maximum efficiency from the system. I got this from some work Albert Killian did, and what you can see is that if you have a standalone campaign, what tends to happen over time is that coverage with LLINs will decrease. And this data from Uganda illustrates that point. The last mass campaign was done in 2010, and what you can see is that the retention coverage with LLINs will decrease. Unfortunately, Malaria Consortium today is involved in distributing over 20 million nets to reverse this trend. So if every 3 or 4 years we were to have a campaign, what would happen is that you'd have intermittent increases. If you used only a continuous distribution channel, what would happen is it would take you a very long time to achieve high coverage. And so what you need is a mixed distribution model that takes advantage of the rapid increase through campaigns and the stabilization by using continuous distribution channels. In deploying parasite-based diagnosis, we have been able to show that it's possible to use microscopy as well as RDTs at facility and RDTs at community level. It is essential that during the training, there's a practical session that allows the health workers to be able to practice and get confident with the tools. We've also learned that it's important to have clear guidance on how to handle parasite-negative cases. Without this guidance, it becomes difficult for health workers to be able to adhere to guidelines. And sadly, expert microscopy in routine settings is a myth. The quality assurance systems are therefore critical to promote the confidence in results so that the utilization of these tools is optimized. Chloroquine, we all know, was the mainstay of case management. It's been difficult to displace chloroquine with ACTs, but it's been possible. The adoption and use of ACTs is not linear. There are early adopters, and there are those who take longer to have confidence and use. That confidence is promoted when you have evidence on the efficacy as well as the effectiveness of ACTs. Test before treat is feasible and acceptable. But again, the management of non-malaria fevers is challenging and requires urgent attention. Now, in our work, we found that capacity building is misused. How often do we say we're capacity building when we're actually not doing that? And that training is not purposive enough. And as a result, it's difficult to measure outcomes. We've also, from our experience, learned that adults learn better with methods that are tailored to their capabilities. And being a trainer is not about being an expert in the field. It's about knowing your subject, but also knowing how to deliver the content. In Nigeria, we've been able to show and learn that you can link integrated supportive supervision with on-the-job capacity building. The work we've done on NTDs in South Sudan and Ethiopia, we've been able to show that integrated disease mapping is feasible, and that by having good quality maps, you can inform NTD strategic plan development. And the caution is that when integrating, you really have to be careful about the diseases you bring together and the platforms you use in delivering NTD control. Containment of artemisinin resistance, work we're doing in Southeast Asia, shows that it's successful to contain resistance using a combination of intensified surveillance, monitoring and evaluation, implementation research, behavior change communication, and advocacy. And that using mHealth and tools can result in surveillance that provides real-time data that can be used. However, it has to be contextualized. Now, some of you may have used this tool. It's NetCalc. It's a tool which, through the work of Albert Killian and ourselves, we've been able to develop a user-friendly tool which program managers, as well as others, can model coverage of LLINs. And this is something that's now being used in many countries. Health worker performance management approaches. In Nigeria, we've included adult learning techniques in the capacity building modules, and these modules have been harmonized, accepted by the National Malaria Control Program and its partners, and are being used at scale. The Clover project, which was a multi-country program over a 7-year period, epitomized what we call using malaria as the entry point into health systems. And this is now something that's fairly acceptable and used. Looking ahead to the next 10 years, we're going to be looking at the role of seasonal malaria chemoprevention as part of an integrated malaria control package and what it can contribute to subnational and regional control. There's an opportunity for cross-continent learning for malaria elimination between Southeast Asia and Africa so that the aspirations of many African governments can be contextualized into a reality. After all the research, what is the role of the malaria vaccine RTSS? What do we do next? And for NTD control, how do we and how shouldn't we integrate? It's important to involve the private sector, yes, but we have to think markets and do public health. And in our work in health worker performance improvement, we are going to look more at how we measure and monitor changes and finding smarter ways to target relevant supervision as opposed to just supportive supervision. Using electronic systems for information and logistics management, it's important that the data is relevant to those at the bottom of the information chain. and appreciating the drivers of community acceptance and continued use of proven malaria interventions, understanding what drives adoption and continued use. Innovations in financing. We have to innovate, and we're going to be exploring mechanisms from within country and beyond. I must say that our work would not be possible without the commitment and efforts of our staff, the Malaria Consortium family, past and present, the support and stewardship of national governments, funding from our development partners, the efforts of collaborating organizations and institutions, the cooperation of our beneficiaries, the foresight and stewardship of our leaders and board of trustees, and of course, the inputs and contributions of many others. We thank you all.
Thank you, James. Could I then ask if there are any sort of immediate questions for clarity on the presentation, any things that people didn't understand or wanted a bit more description of before we move to our panel members? If not, I will then ask Bernard if you would like to respond with some thoughts and react to James' presentation.
Sure, thanks, Charles. Well, first of all, thanks for inviting me to be here today. Even though it's the 10th anniversary of the Malaria Consortium, I think many in the room know there was a preceding phase, and seeing Sylvia Meek and Jenny Hill and Graham Root here, I must say that not only is the Malaria Consortium very successful, but it also must be very stress-free, because these people look younger today than they did 15 years ago. Anyway, it's, I think those of us who had the opportunity to work with the Malaria Consortium and see how it's grown over the years are remarkably impressed by the range of activities, the way the footprint has expanded from some initial work in Uganda and other areas to being a very effective partner in many countries where PMI have programs, both in Africa and also in the Mekong. And I think we share a lot of the same viewpoints that James has just pointed out. The need to be very practical in the approach to controlling malaria, this idea that not one size fits all. And I think the Malaria Consortium's presence in countries obviously points that out repeatedly, that I know many of us in Washington and Geneva and London sometimes may think that whatever new tool or new approach has been developed was just going to be an easy push, and there'll be a very effective way to get this out in a very short period of time, and yet that seldom is true. I mean, some countries obviously can do things much quicker than others, and the systems, the policies that need to be in place, et cetera, that allow for uptake of these interventions is quite different. And I think the Malaria Consortium's experience in these different countries helps provide the evidence base and be an effective partner in that, from which we all can learn. I think the other thing we all recognize is that the Malaria Consortium remains a learning environment, as James has already pointed out, and that I think you were also referring to, if I understood correctly, there is a bit of an ongoing and false debate on disease control programs versus health system strengthening. I think we share the viewpoint that, particularly in the African setting, where malaria is 30 to 40% of outpatient visits and half the pediatric admissions in hospitals, that all of us who are interested in strengthening health systems, malaria is a great disease to work on and to lead with that. And I think we all need to do a better job of actually documenting that and explaining to people what exactly is going on. And at least I'm convinced that in areas where malaria is being controlled, the health systems are actually being unburdened in a way which would allow them to start functioning, hopefully, as more effective health systems for other diseases as well. And we look forward to continuing to work with the Malaria Consortium around that. As you're probably aware, we do work closely with the consortium in Malawi and Mozambique and Ethiopia and Ghana and Nigeria and in the Mekong. The Mekong, as Sylvia sort of referred to in her remarks earlier today, is a primary interest for a lot of us because of the emergence of artemisinin resistance. I have always been skeptical of this term containing resistance in the Mekong, because I think that's a bit of a faulty concept, and I think most people have moved to the idea that we need to figure out how to actually get rid of malaria in the Mekong, and the Malaria Consortium, I'm sure, is there for the long term, and I think that's the other point here, that having seen where the consortiums come from, the fact that you're celebrating your 10th anniversary, I look forward to the 20th and the 30th anniversary if I'm still around, because I recognize that within the consortium itself, and also here with the commitment of the UK government to malaria, we're all in this for the long term. So those of you who are involved in the consortium now, it's a great thing to continue to be involved in, and we look forward to working with you in the future on this. Lastly, and having some discussions with the consortium with Charles and James and the team the other day, I'm also pleased that the consortium is also interested in addition to continuing to look at the reduction in malaria and the health burden on communities, doing more work on issues related to the burden on health systems and on families, out-of-pocket expenditures for malaria. What are the benefits to communities once malaria is controlled? Because malaria is an impediment to development, and we all need to rally together to make that case, because the threat to malaria going forward is not only drug and insecticide resistance, it's financial commitments from countries themselves and from external donors. And frankly, there is some perception that malaria has had its heyday, so now we need to move on to other things. So the advocacy part of the Malaria Consortium also can't be underestimated. We all need to continue to make the case that there's a lot of unfinished business in malaria. The gains are important. If we don't continue, these gains will be lost, and we all need to work together moving forward on this.
Thank you. Godfrey, would you like to add something?
Sure. Mr. Chairman, distinguished guests, as we celebrate 10 years of Malaria Consortium, I think we need to recognize our achievements, but also identify the challenges and the opportunities for the next couple of years to come. Malaria Consortium in Uganda has grown from a one-man team that was supporting the Minister of Health, providing TA, now to a 100-man and woman team, employing some of the best public health professionals in Uganda, implementing programs ranging from malaria control to the wider child survival, and a little bit of NTD work. We are now, as an organization, a strong partner at the Ministry of Health, together developing policies, guidelines, and then taking those policies and guidelines right in the field, implementing and evaluating high-quality programs. 2 years ago, when I was giving a presentation at the joint Uganda Medical Association, Uganda Veterinary Association conference on the theme One Health, I cast a bleak future to the malaria control program in Uganda, because everybody would be referring to malaria control in Uganda, coming close to pre-elimination. I said that was a fallacy. Why did I say that? And I still believe so. Uganda still has one of the highest burden of malaria, especially under fives and pregnant women, with the third highest malaria mortality-specific death in Africa, and with one of the highest entomological inoculation rate in Africa in some of our districts, up to about 1,000 bites per year per person, with a high burden, about 30 to 50% of outpatients being malaria, 15 to 20% of admissions being malaria, and 9 to 14% of inpatient deaths being malaria. And yet our program, as a country, has had very little long-term strategy that is consolidated and towards a strong malaria control program. Now, though, I'm beginning to see some kind of light at the end of the tunnel. I know that in order to have a strong control program, we need scaling up for impact. We need key tools, including long-lasting insecticide-treated nets. We need IRS. We need an effective diagnosis and treatment program. And all these need to be taken to scale. We need to sustain these for a while in order to achieve impact. I'm beginning to have some hope, especially for a strong program, because in Uganda now, like Charles and James has said, we are on the way for the first time to achieving universal coverage of LLINs with support from partners, PMI, Global Fund, USAID, and the Ministry of Health and ourselves. And Malaria Consortium has been at the forefront of this. We're leading and supporting the Ministry of Health to distribute 20.5 million nets, of which we've already done 15 million, 12.5 million over the past couple of months. We do hope to complete these 20.5 millions in the next 2 months. And with that, we hope that we shall begin to see good coverage of LLINs. Malaria Consortium has also continued to support the Ministry of Health and to demonstrate in one region of between 5 and 9 districts, we have a combination of programs ranging from LLINs distributed through universal coverage and also continuous coverage, ICCM, a solid holistic case management program, behavior change communication, operational research, strengthening referral, and capacity building for health workers through integrated support supervision and training. And then in these districts, we've been able to demonstrate, one, sustained LLIN coverage, retention, and use, a little above the expected decay. We've been able to demonstrate in this region a reduction in prevalence, parasite prevalence from 39% to 15%, and anemia from 45% to 32%. And hundreds of children have accessed treatment for for malaria, pneumonia, and diarrhea through 15,000 community health workers and health facility health workers. We've done a modest reduction in mortality, under 5 mortality, from 81.2% to 76%. We are the lead partner in Uganda in scaling up ICCM, being responsible for 17 districts out of 35 districts in Uganda, and have been the pioneer in promoting the use of rectal artemisinin and introduction of RDTs at the community and the health facility level. In the area of RDTs, we've been able to demonstrate that use of RDTs at case management has significantly reduced the use of SCTs, which reduces, I hope, the impact or the pressure on SCTs, and also looking at the cost as well. We are gathering evidence, which I think is the opportunity that we can build on, and this evidence that we share with the Minister of Health includes looking at options of sustaining high coverage of LLINs through some of our projects that we are implementing, like the Net Culture project. We're doing a study on malaria in pregnancy. Why is there consistently low uptake of IPTP? We're looking at community referral systems. We're looking at options of motivating community health workers, particularly who are volunteers, to continue to work. We're looking at the behavior of malaria in the community over a long time through 2 studies, the Beyond Gaki study and also the insecticide resistance studies. We're also exploring different avenues of increasing, taking to scale RDT use, like in the UNITAID supported RDT project, and also at the forefront of introducing the use of injection artemisinin for severe malaria. With all this evidence and the net coverage that we do hope to achieve in the next couple of months, I think we are poised to start thinking about a solid control program, certainly not a pre-elimination program. Challenges do remain, but I would like to concur with James that Uganda, we still have challenges, but I think we can take opportunity of what we have done so far to be able to take to scale what I call 3D, taking to scale the programs that we are implementing, also increasing the scope, in other words, putting a combined program, and then in terms of time, we need at least 5 years or so to be able to see a solid control program. Thank you, Mr. Chair.
Thank you, Godfrey. And with that, I'd like to hand to Desmond Chavasse, who's one of our partners and also operates across a lot of Africa from Population Services International. Des.
Thanks, Charles. Once again, a real pleasure to be here. Thanks for inviting me. Looking around the room, it's a real trip down memory lane. It's a reminder that many of us have been in this game for a long time, many of you a lot longer than me, but it's terrific to see that sort of continued, sustained commitment from members of this community. I'm going to limit my comments to malaria. I'm going to zoom out a little bit, perhaps, and just divide my comments into where are we now, where do we actually want to get to, and how are we going to get there. I'll be as brief as possible so that we can get as much time for questions. Where are we now? I mean, the news is exceptionally good. We have a 1/3 reduction in incidence and almost halving of malaria-specific mortality since 2000. So this is really excellent news. We've had huge increase in the amount of funding from sort of 100 million in 2000 up to 2.5 billion in 2012, which is about half of what we've projected to actually need, the 5.1 figure from the Global Malaria Action Plan. In sub-Saharan Africa, about 42% of people now have access to sleeping under a treated mosquito net. 135 million people protected by IRS. In 2005, the community delivered 11 million ACT treatments. In 2012, that was 331 million. So some really fantastic progress there, both in terms of the inputs, the scaling up, the actual impact on disease. But it's exceptionally fragile. Where are we actually trying to get to? Do we just want more of this? Is it just scaling up? Is that what we're trying to do to achieve those coverage targets and then just carry on? Probably not, because of course resistance will get us in the end, whether it's insecticide or drug resistance. So therefore, we need this elimination goal. And of course, that's different. That means we need to do different things. We can't just do more of the same. Of course, scaling up control is on that pathway to elimination. So yes, we do need to just scale up in many places. But we also need to make sure that countries are beginning to think about the future goal, because that goal is so different than just more of the same and more of it. And I think articulating that carefully so that people are getting on board now for that different goal is really important. And I think while people are reasonably comfortable with that at the international level, I'm not sure I'm hearing all of that rhetoric fully understood at the country level. So some work to be done there. So how are we going to get there? If that's actually where we're trying to get to, how are we going to do that? I think really having that roadmap clearly laid out and having that process of advocacy at the various levels to make sure actually the community is aligned around this, because there's clearly a lot of debate, and that lack of alignment is confusing at country level and not helping make sure that everyone is moving in the same direction. We're going to need more money. A lot more money, and the money needs to be more simply available. Just the processes for accessing it and spending it and converting it into the appropriate activities needs to be simplified. Are there some sort of performance-based financing approaches that would make this easier? A lot of us have been watching some evolution in some of the major donors in malaria recently. How's that going to play out, and how can we just simplify the process? So I think, coming down a level and talking about some specific interventions, LLINs, how do we scale up LLINs? We know how to do it. There are lots of these different models, and yet really 42% just isn't enough. 42% having access to using treatment is not enough. Again, with a bit more money, there isn't really much controversy here. All the tools are here. You've seen NetCalc. Why isn't this happening? Why aren't we doing better? At the end of the day, it's really about the amounts of money and those funding mechanisms that need to be simplified so that we can rapidly scale up. Of all of the interventions we've got, that really is the simplest. Some of the other aspects, obviously we know that something like 40 to 80% of malaria fevers are being treated in the private sector. So how can we improve case management through the private sector? Needs to be done. That's exactly the work that we are collaborating directly with the Malaria Consortium in 5 countries with support from USAID. Very interesting piece of work, but clearly extremely complicated. Needs to be done. We need to move forward with that. But not all this stuff is equally simple. I still think a certain amount of stratification, doing the easy stuff whilst not forgetting the difficult stuff and getting on with that too. So, in summary, I think the call would be a little bit more alignment, really. There's so much going on in this field with so many partners, and it would be really nice as a community if we were able to align a little bit more at the various levels. And of course, there are so many pieces here. But I look forward to obviously playing my part and PSI's part in that. And with that, I'll stop. Thank you.
Thank you, Des. So that brings us to the opportunity for questions for the panel. Again, those listening on the internet, or if you've joined us since we started, please do feel free to raise a question using Twitter if you have access to that on hashtag MC10, MC10, and the question will come through and it will be shared with us here. But then can I ask anyone who does have a question in the audience here, if you can sort of just stand up and give us your name and your question so that the camera can track to you relatively readily so that those on the internet can also hear the question and see who's asking it. So do we have any questions around the room? Yes, please, yeah.
Neil Squires from DFID. You mentioned the need for increased financing. I'm just wondering, to what extent do you feel that financing for malaria control will increasingly come from national governments themselves? We've seen a number of the countries in Africa with increasing natural resource revenues, but have not yet seen much evidence of that being channeled into public service delivery. Clearly, with the global economic crisis, there's limited potential for increase in international donor financing. And so it's the pressures that are being brought to bear on ministers of finance to understand the economic arguments for investing in malaria, whether those are being made and whether there's any response to that yet. Thank
you, Neil. As you raise that one, Des, would you like to have a first go?
It's easy to raise the questions, isn't it? So I'm not sure I am the best person to answer. What I would suggest is that if we're not going to be expecting that much more money from the international donors, and I feel that is the trend, and therefore we will be looking to national governments to increase their commitments, then yes, I think there's going to need to be significant investment in advocacy to really try and make the case. I mean, obviously, there's a lot of, some countries are much better able to contribute more than others. So a little bit of stratification there, which ones can do more, and what are the barriers to them doing more? Is it a lack of understanding? Is it the economic arguments? Have they not fully understood the benefits of the investment now? I don't really know, but certainly an analysis in that direction. If that's where the additional money is going to come from, i.e. national governments rather than international, then we need to move in that direction. And if we're not successful, then you've got to, cut your suit to fit your cloth. Thank you. Have we got the right mix of interventions? If we've got a lower amount of money, if we can't do more, are we right to be moving towards elimination across the world? There's a circular argument here. How do we eventually make sure that we have got, in a particular country, in a particular point in time, the appropriate plan and the appropriate set of activities that's matched by the available budget? There's quite a lot of mismatching at these various levels. So that's sort of where the alignment of making sure that countries are getting a consistent messaging and consistent support with how best to do that.
Bernard, no doubt you have this debate regularly too. What thoughts on the financing?
Well, I think the good news is that financing hasn't gone down from the external donors despite the global economic crisis, and I would congratulate the present government here in the UK for continuing to move forward on their commitment. So that's the good news. And similarly on the US side, our budget actually goes up every year. But is it enough to meet all the needs? Absolutely not. Along with sort of what Des was saying, I think many countries, it's not only about money. Some countries do have absorptive capacity issues. So just having more money there doesn't necessarily help get better access to services for people at risk. So I think country by country, which countries actually are able to use additional resources. And our experience, at least in PMI, is that there are cost efficiencies over time, and it gets back to this whole learning environment that, just as an example, in Ethiopia, our implementing partner is now, that's involved in indoor residual spraying, has now moved to evaluate actually community-based indoor residual spraying, which are managed by communities themselves, and the cost efficiencies there are pretty significant. I think there are similar issues when it comes to delivering bed nets and others over time. I mean, we tend, when we start off without knowing necessarily how best to get things going, to do things in a way which may or may not be the most efficient ways of doing things, but as we have more experience and share things and look country by country, there are some cost savings there which can then be hopefully deployed to other ways. Secondly, malaria needs to do a better job of engaging other opportunities with other programs. Some of what malaria needs to do shouldn't put additional burdens on health systems. So I think a perfect example of that are LLINs. They're not best delivered in these campaigns by having the ministries themselves only do this, which is why having the Malaria Consortium and other groups out there with who are able to manage this and support programs is very useful. But within the ministries themselves, when it comes to case management of malaria, when it comes to surveillance systems, when it comes to procurement supply chain management systems, I think we're doing a lot of this, but we need to do a better job of figuring out how to work better with the other programs, HIV programs, NTD programs, maternal child health programs, reproductive health programs, to actually create further efficiencies here. The issues of governments themselves putting more money, absolutely. They should. Some are, some are not. And there is some evidence in some countries that governments are now actually starting to put less money in the health system as there is more external donor funding in these, and that's what we want to avoid. I see that one colleague from the World Bank is here. You know, most of us don't talk to ministries of finance, but they are sort of central to this. And I think the World Bank is an incredibly important player in the space. We all are sort of waiting to see where that's going, but we all recognize that the World Bank can actually help influence ministers of finance to be willing to put more of their own government resources into the health sector, and certainly in countries where malaria is a big burden, a lot of that should go towards the malaria efforts in those countries. Other people, frankly, I'm not a finance person or an economist, but I know people are looking at malaria bonds or looking at an innovative financing thing. I can't comment on that. I don't really understand that, but I think whatever happens in the future, we need to keep our eye on the ball of where we are now and make sure that we don't start backsliding while waiting for the next innovative thing to come along.
If I may actually add a comment, I think that the question of what it is we're asking governments of areas where malaria and other diseases are highly endemic, we're often, I think they're looking at it from the light of where they're coming from rather than where they're going to. So I guess the question is whether we can get better at explaining what the burden to the health system will be when we've finished the sorts of interventions which donors are currently paying for, and what the level of required ongoing support and commitment is that's required so the economics make more sense, rather than it just seeming too big for them to be able to bite off even a piece of it and make it work. So I think this notion of, one size not fitting all, the question is, at what point can the government actually believe that they can put resources in to match it, and finding ways to have that debate with those who talk to the ministers of finance, and getting better at talking to the ministers of finance, I think, is going to be a critical tool as we move forward. Can I then open it up for further questions? Anyone else have a... Yes, thank you.
Jeff Butcher, I was a trustee, and I come from a sort of caveman period of malaria research. We don't hear anything, and haven't heard for a very long time, about environmental control. Are we likely to hear anything like that in future? And the other question is, there is a group of people who are looking at naturally occurring African plants. They don't get much money for their research, for potential anti-malarial compounds. Is there anything of value in that at all?
Thank you. James, would you like to comment?
I'll probably say, I think a lot more, the direction we're moving more is to things around integrated vector control management. And we've seen examples where people have tended to, in a way, misunderstand environmental control. So currently we have proven interventions, and I think the point is how to ensure that those proven interventions are deployed at scale, because the effort that it takes to do all these things requires not only time, manpower, and resources, which is very, very limited. So you really have to focus on what you can get the maximum out of using the minimum resources available. Yes, we have medicinal plants, but again, I think it's how the messaging is carried out, because when Artemisia started, people tended to use Artemisia for treating malaria. And we know that that is a practice that does not give you the adequate therapeutic level in blood. And so I think the research that's necessary needs to be done, but we have to also then be careful about the messaging that could mislead the communities out there.
Thank you, James. Bernard, would you like to add a comment?
No, other than to say that obviously the whole area of continuing to invest in research is crucial. I mean, where I'm sitting now, where we're supporting programs, is primarily focused on operational research related to existing tools. But you're probably aware there are some, I think the other good news in malaria, there's some other things which have been developed over the past few years, which I think are good ways of investing in research. I point to MMV, the Medicines for Malaria venture, which are working with numerous companies and academic institutions to look at new compounds which can be brought forward in a way which hopefully will speed up the time in which we would have some new treatment modalities. The IVCC, which some of you are familiar with, which is the similar thing on the vector side, looking at new insecticides, which, working with the private companies, some of which are represented here, can be brought forward in a more efficient way to make them available for use in vector control. On the environmental side, I won't add anything other than what James is saying, but obviously one of the challenges in the Mekong and the challenges in Africa obviously are quite different. Frankly, I think some of the successes in the Mekong have been a result of cutting down the forest and less what we're actually doing for malaria control, although I don't want to underestimate the importance of that. Whereas obviously the ecologic changes in Africa of cutting down the forest creates more malaria because of the difference in the vectors. So these are issues which are important, but figuring out what we mean by environmental control and how that plays into our ability to deploy tools where we do have an evidence base that they're going to work with is something we all need to keep our eye on and contribute to that understanding and discussion.
Thank you. Godfrey, do you want to add anything? Not that one. Yes.
Mark Moody-Stewart from the IVCC. I just wanted to follow up on Bernard's remark and say something about funding. I mean, we are fortunate in the IVCC working with private partners to have a number of new compounds coming on, but they require funding. If there was no hurry, I personally would be reasonably confident that much of this funding would come from the private sector when and as they discover other uses for it, agrochemicals and so on. But that takes time because it has to be put into their priorities. And it is urgent, as several panelists have said, to find compounds to overcome resistance. The other barrier is to speed up the regulatory process. We're fortunate in having funding from PMI, from DFID, and predominantly from Gates. I wondered whether you had any comments on how we could make the process of regulation and regulatory launch of this more efficient.
Thank you, Mark.
I'm not sure, again, I'm not sure I'm the right person to say what the methods are, but only just to absolutely echo the need for this. You know, the history tells us that private sector needs the incentives to innovate and come up with new products in malaria control, and if we don't have the regulatory processes in place to facilitate that, it's already a hurdle anyway. They already need to produce huge amounts of their own money, or rather invest huge amounts of their own money to come up with these new product innovations. So we're really not helping if having done that, they're then slapped down because we don't really have the regulatory processes in place to allow them to get the return on that investment, financial return on that investment. And obviously the community gets the better products that help control malaria. So, yeah, without pointing any fingers, I think, you know, there are clearly organs that need to be looking at what they can do to facilitate this whole process so that new products, you know, such as, you know, combination nets or, you know, new insecticide molecules can be accelerated into our armory to deliver and continue the fight. That, we don't really have much excuse for not making progress there.
Bernard?
Yeah, that's such a crucial issue, and I can assure you that those of us on the donor side recognize the challenges, and we do try to use our influence, and some of the bodies such as WHO, which is not only on the WUPA's process, but also on the WHO pre-qualification, to try to figure out how to support those, facilitate in a way which can actually not create further bottlenecks and barriers, but can actually facilitate it. We haven't, frankly, been that successful in some of this yet. I think there's a good example on the malaria RDT side, which again was a new intervention which came on board. And some of you may be familiar with the group, the NGO FIND in Geneva. Some ex-WHO staff were involved in the actual work around this, looking at an approach to quality assurance testing. WHO staff themselves were part of that. The work, I don't think, was done very efficiently. It actually has driven towards better products in the market. And I think it's a good example of where WHO takes ownership of things in which WHO is involved, but isn't necessarily totally within WHO itself. So it's just one approach, which I think probably deserves some further exploration, because I know that most of the donors will need to rally around some sort of equality standards, and that tends to be either, in the case of drugs, our own FDA, the EAMA here in Europe, similar sorts of national regulatory authorities for drugs, but on the vector control tools and on RDTs, we tend to rally around the WHO pre-qual and WUPIS. And and also as donors, we try to align our procurements together around these things, so we're not coming into a country and having different things. I think the other aspect of regulatory, though, which is frequently ignored, underestimated, is at the country level. The national regulatory, when you do have a good product, that frequently is undermined by total lack of any sort of oversight at the country level on how to make sure that there's suddenly not a free-for-all with lots of products coming into the country which are actually undermining the good quality products we know that many of you are manufacturing and we're able to purchase. National regulatory authorities seldom receive any real support, and there are some very good people who actually want to do a good job, but they don't have the sort of support they need in order to do their job. And I think we need to do a better job on that.
Thank you. And I think I would add, from Malaria Consortium point of view, we are very keen to see if we can find ways to increase the capacity in countries to be able to do the necessary bioequivalence and testing regimes in countries in order to up the pace in the terms of assuring the quality of product that's going into the countries. And that's something I think for discussion over the coming weeks and months as to how we can sort of up the capacity of approved laboratories for doing that. It's something that I think if we're going to be serious about reducing the risk of poor treatments or non-compliance because of incorrect products coming in or poor products coming in, we need, as a community, as a sector, to really be working hard to get the capacity up to test a product that's in and help governments to fulfill their responsibilities. Interesting, I think, something as you might be able to comment on, I think talking about sort of Myanmar and in opening up, actually you've been able to relatively quickly get monotherapies out and ACTs in regulatory terms, and it's been an interesting experience, I think, to move that forward. So time for one more question. I wanted to, Graham, yes.
Thanks, Graham Root, Montrose. What struck me was I've just been reflecting on the last 10 years and looking ahead to the next 10, and I think while the efforts, I think, of everyone in this room, and particularly Malaria Consortium, are commendable over the last 10 years, perhaps the biggest impact on malaria control has been simply economic growth in Africa. And over the next 10 years, to answer perhaps Neil's question about financing and governments and where's the money going to come from, I would think it's going to come principally from African economies growing, urbanization, people getting richer, and being able to pay for their own treatments. And I think that's what will sustain the gains that we've made, rather than the broader efforts of the international community putting in donor-funded programs on malaria control.
Want to comment?
Yeah, to agree, absolutely. And as we all know, everyone's heard that 6 of the 10 fastest growing economies of the world are in Africa. And I can tell you where I'm sitting, we have people with our own U.S. government who are saying, why are you continuing to put money into Angola? Yet I think, again, malaria, there's a supposition that just because there's economic growth, that the equity gaps are automatically filled. And I think in countries where there's evidence that there is good stewardship of that growth and that indeed governments are figuring out ways to make sure that this wealth becomes part of a societal good, then that certainly needs to be supported. We have fought back against the idea that Angola doesn't need external support for malaria control because they have all this oil wealth at this point in time, because malaria, as we all know, is a disease of the poorest of the poor in communities which frequently are not only beyond the reach of the health system, but beyond the political system. And I think those of us who are involved in these discussions at different levels need to keep that in mind too, that it is an equity issue also. So I don't disagree that part of that, we do hope that as economies grow, that more of that wealth can come from people's pockets for their own and from governments themselves. But there will be a lot of people over the next decade who we need to make sure are not left behind in the midst of all of this.
Okay, thank you, Des, yes.
So, yeah, absolutely agree with 2 caveats. Not sure the 10-year time frame, that's a little ambitious. And let's not forget that the people at greatest risk are those rural and poor. And, you know, I was in Equator and Northern DRC not very long ago. I can tell you it's going to take a lot longer than 10 years. Now, of course, I've chosen an extreme example there. But I think the spirit of what you say is correct, but I think it may be a bit more than 10 years.
Neil, do you want to add one more question?
It was just to reflect on the comment that was made that malaria is a pathfinder for health system strengthening. A lot of what you've been saying actually demonstrates that it's not the health system that necessarily is dealing with a lot of the malaria problems. It's the extended health system. So the interventions, bed nets, community treatment, these are all things that are done largely outside of the health sector. And I'm wondering whether we've done enough to capture the lessons that malaria has for broadening our approach to health service delivery, so that it is an approach which empowers communities, looks at greater self-reliance, works effectively with the private sector, because most people get their treatment directly from drug peddlers or others in the community. And actually, if people are going to the health system, it's generally because the whole prevention issue has failed. So the bits of the health system that are important are presumptive treatment in pregnancy and those key elements of delivery. But I'm not necessarily sure that we do enough of making sure that every clinical contact counts in terms of delivering prevention messages. So that's one potential area for growth. But also the key message of capturing the importance of empowering communities for an effective response and encouraging other aspects of the health service to think about this as a delivery approach.
Thank you, Neil. I'm conscious that we now need to move on. That was actually a perfect segue, so thank you for that. We're going to move from this conversation, before I do, though, to thank the panel that have been talking about this first part of this, and to say we're going to move now to talk about linking the community and the health system. So